begin, a couple of quick announcements. Next week we have transplant M&M once again. And the following week, oh wait a minute, I have it right here. Following week, Robert Montgomery from Johns Hopkins is going to speak to us on overcoming obstacles for sensitized kidney recipients. But today, we'd like to welcome back Colonel Michael Davis. I say welcome back because, as some of you may recall, Mike performed his general surgery and residency here, completing that in 2005. He then went on and did a fellowship in plastic surgery at the University of Alabama in Birmingham while on active duty, and then beginning his payback time with the Air Force. Spent time at the Bagram Air Base in the, what do they call the hospital there?
Joint Theater Hospital.
Okay. In 2010. And now he's back here at SAMMC, again as a plastic and reconstructive surgery, but more importantly to this group, he's Chief of Reconstructive Surgery and Regenerative Medicine at the U.S. Army's Institute of Surgical Research. And today, Mike is going to talk to us about regenerative and reconstructive modalities driven by a decade of combat. So, welcome back, Mike. Thank you very much. Oh. Yeah, go ahead and put that on. Guys at top will control the lights. And you're just going to have to advance.
That'll be fine.
Okay.
So good morning, everyone. Does this sound right to you? Okay. Again, my name is Michael Davis. I'm a plastic and reconstructive surgeon by trade. And as Greg said, I'm Chief of Reconstructive Surgery and Regenerative Medicine at the San Antonio Military Medical Center and the Deputy Commander at the U.S. Army Institute of Surgical Research. I want to thank Dr. Abrahamian for inviting me out to speak. It's hard to believe it's been 10 years now since I had the honor of being up here and giving transplant grand rounds. I'd like to thank Dr. Half and everyone here for coming out to listen to my talk. What I'm going to talk today about is something that's near and dear to my heart, and that's restorative medicine. And the reason it's near to my heart is that having been deployed downrange and taking care of these young soldiers that really sacrifice for us every day and occasionally sustain devastating injuries, I saw that, and I also saw the lack of ability we have to really restore them either anatomically or functionally. And it became my professional drive then to come back and start a research program in order to hopefully provide some means of advancing the science to help restore their form and function. What I'm going to talk today about is some regenerative medicine and reconstructive surgery modalities that have really been advanced by this decade of combat. Usual disclaimers, these are not the views of the Department of Defense. So what we'll talk about is an overview of Operation Iraqi Freedom and Operation Enduring Freedom. Really define what the need is here to help these folks and some of the devastating injuries that they sustain on a frequent basis. We'll talk about some definitions with regard to regenerative medicine and how the government and DoD are trying to meet the need of these soldiers and rehabilitate them. We'll talk about some advances in reconstructive surgery. That again, it's another modality in which we can hopefully restore some of their, give them some of their life back, and we'll talk about the future of restorative medicine, and I'll put a plug in for some of the research that I'm doing in the Restore program. So the Mayo brothers are attributed with this quote shortly after World War I, and that is, "The only victor in war is medicine." And that's really never been more true than it is after this decade of war. The type of injuries that we see, a type of warfare and enemy that we have really inflict massive, devastating injuries on these patients. And it's, again, it's IED-based warfare that, we have advances in critical care medicine, body armor, and the science of taking care of combat soldiers that really prolongs and enables them to survive but then they carry this burden of survivorship that's never been seen before in any war. So just to put it in perspective, over the course of Operation Iraqi Freedom and Operation Enduring Freedom, about 1.6 million soldiers have been deployed. 50,000 of those have been wounded in action. 40%, or about 20,000, have suffered severe extremity and craniofacial injuries. Again, having great body armor protects the torso, prevents immediate death, and allows oftentimes salvage of these patients, but we see multiple extremity amputations. We've had 490 multiple amputation patients, 275 upper extremity amputations, and we'll talk about why that's important and unique. 259 of those have been unilateral and 16 have been double. 43 triple amputations and 5 quadruple amputations. So this is a figure that was recently published in the Journal of Trauma just last month. And this is a tribute to military trauma care and research. This, most of the money that's gone into DoD medical research has been focused on point of injury care, taking care of these patients right after they're injured, preserving their life, getting them resuscitated. And so what we see here over the course of 2005 to 2013, despite an injury severity score having gone up from more sophisticated IEDs and more sophisticated warfare by our enemy, our case fatality rate has dropped. And that is a real tribute to advances in care. So it's gone from about 18% now down to about 8%. And that's the lowest it's been in any conflict we've ever had. And so the challenge in the future will be to maintain that as the war draws down, so that if we ever engage in another war, that we keep this case fatality rate very low. But again, although we save these lives, we create a different problem. And it could be viewed as a good problem or a bad problem, but I like to view it as a good problem. But we have to take these patients that have survived but have a tremendous burden of survivorship and help restore their form and function and give them their lives back. So again, this is, in the upper left, this is what's termed an MRAP, a mine-resistant ambush-protected vehicle. And these have largely taken over as the primary troop movement vehicle. And it prevents immediate death from IEDs. When they roll over an IED, it protects from the blast. Although they may get calcaneus fractures and spine fractures, they do not die as they would with a Humvee. And then this is a picture of modern body armor that, again, effectively protects the torso, but leaves the extremities unprotected. So these are the types of injuries we see on a not infrequent basis. There's really no good standard reconstructive modality that can reconstruct any of these wounds. So we really need answers. And again, these guys are 18, 19, 20-year-old soldiers that their lives are turned upside down in a heartbeat. And we really owe it to them to help them down the way. So what DoD has come up with over the past 6 years is they've developed what's called the Armed Forces Institute of Regenerative Medicine. And this is not really a brick-and-mortar institute. It's a foundation that basically funds civilian institutions to do some of this research that hopefully in the end will translate into real benefits for our soldiers. There have been 2 iterations of this, AFIRM 1 and AFIRM 2, totaling about $350 million. And this research basically encompasses all of regenerative medicine, but also vascularized composite allotransplantation. This used to be known as composite tissue allotransplantation. And this is transplanting hands and faces most commonly, but really can be transplanting any tissues to reconstruct a devastating injury that requires very specific tissues. So what is restorative medicine? So restorative medicine is made up of 2 facets in my mind: regenerative medicine and reconstructive surgery. Regenerative medicine is made up of stem cells, biological matrices, and growth factors. What we'll focus primarily today on is stem cells, as that is the primary focus of most civilian institutions and tends to be the kind of the fad of this decade. In the 2000s, it was biological matrices. In the 90s, it was growth factors. But really, I think all these will come together in future years to really truly have some benefit. You can think of it as the stem cells are the seeds, or the biological matrices are the soil, the growth factors, the sunlight, water, fertilizer, that all need to come together to produce truly regenerated tissue. Reconstructive surgery often involves local tissue rearrangement to immediately cover a wound. It can involve free tissue transfer, or what is also known as heterotopic autotransplantation, where you remove tissue from one part of the body with its blood supply and transplant it to another part of the body to reconstruct the defect. And then ultimately there's vascularized composite allotransplantation, which is gaining some momentum but still has some problems, which we'll talk about. So first on to stem cells. So stem cells have kind of evolved over the last 20 years and become much more refined. Broadly, they're defined as an unspecialized cell that gives rise to more specialized cells. It has the ability to self-renew and the ability to develop into different types of mature cells. So you can take a stem cell, and with proper direction and growth factors, you can steer it down any specific tract you want, ultimately to either heal an organ or produce tissues that are missing, or even ultimately to produce a new organ. So just for some definitions, stem cells come in three different flavors, basically. One is totipotent, pluripotent, and then multipotent. For the sake of just defining them so there's no confusion, a totipotent stem cell refers to a fertilized egg and the first 3 cell division products. And these tissues can produce embryonic or extra embryonic tissue. There's really unquestionable ethical drawbacks, and these have never really been used for any unique scientific use that other stem cells can't be used for. Embryonic stem cells, which we hear about in the media often, are derived from a blastocyst about 5 days post-fertilization. And they retain the ability to develop into any of the 3 germ layers, ectoderm, endoderm, mesoderm. The blastocysts that we get these from are either trophoblasts, are made up of an outer trophoblast, blastocele, and an inner cell mass. And it's the inner cell mass that these human embryonic stem cells are derived from. We get these from products of in vitro fertilization that have been donated to science by the parents. So again, this is a schematic of how these stem cells are procured. The blastocyst is penetrated by a pipette. The inner cell mass is then harvested with the pipette and then plated and potentially steered down any of these growth paths to whatever therapeutic benefit you're looking for. As we've seen in the media, there's unquestionable ethical problems with human embryonic stem cells. It's not funded federally. Only a couple states support this research. But luckily, science has been able to get around this problem and created their own multipotent stem cell from a normal somatic cell. So science is now able to take an adult cell, somatic cell, not a stem cell, just any adult somatic cell, expose it to several different growth factors, KLF1, SOX2, NANOG, GOC34, and LIN28, and reprogram these cells to reverse their differentiation. So they become essentially pluripotent stem cells and theoretically act as human embryonic stem cells. Now, we know that's not totally true, but you can steer these down any path of differentiation that you want. There's still a lot of work that needs to be done. There's questions about oncologic potential and controlling the differentiation and growth of these that still needs to be worked out. But this gets around the ethical dilemma of human embryonic stem cells. By far now, science has turned to adult stem cells. These are harvested from mature tissues. They retain the ability to self-renew. Their main function in vivo is theoretically to rejuvenate and maintain and repair tissues that have been injured And so the theory is that, as we age, we lose the ability to maintain these stem cells, and that's a large part of why we age. When in certain clinical scenarios, such as radiation, these stem cells are killed off, and you see the clinical sequelae of that. These stem cells, as opposed to human embryonic stem cells, are able to differentiate into a variety of cells within the same germ layer. So if they're in mesodermal stem cells, they can differentiate into any mesodermal tissue, but they can't go outside of that specific germ layer. So we've been using adult stem cells for quite a while with bone marrow transplantation, but it wasn't until about 1999 that we found that bone marrow stromal cells, mesodermal stem cells, have the ability to differentiate into bone, muscle, fat, and cartilage. But really, you can obtain these stem cells from basically any tissue in the body. It's been found in granulation tissue, skeletal muscle, any connective tissue, and even the heart you can obtain these from. But for multiple reasons now, we have grown to rely primarily on adipose-derived stem cells, primarily because the ease of harvest. Through a variant of liposuction, we're able to obtain these stem cells, and these can, again, create fat, cartilage, muscle, or bone. And so these have really kind of taken over the science of stem cells. And so most of the time you see research that's done on stem cells, it's adipose-derived stem cells that they're using. So lipoaspirate contains about 1,000 times higher concentration of stem cells than bone marrow. And really over the past 10, 15 years, it's grown a reputation for safety with very few limitations. One of the ways that we really found out the power of adipose-derived stem cells is from reconstructive surgery, primarily with regard to the breast in patients that have had radiation to the breast for oncologic reasons. So oftentimes these patients present with some kind of contour abnormality in association with the radiation change. And so the idea was, at first, you could take this lipoaspirate and do a fat transfer, place it in the breast to restore the contour abnormality. But we also found that the radiation change was significantly improved. So we knew there was something else going on. It wasn't just the filling of the defect that was preferential. So that kind of opened up the science of stem cells and finding out what part of that fat transfer was truly beneficial. And what we found is it wasn't the adipocytes, the mature adipocytes. It was actually the stem cells in the vascular stromal fraction of that lipoaspirate. So now on to the next step. So now we know these stem cells can go down any differentiation pathway within that germ cell, or within that tissue type. So the next step would be in vitro tissue engineering. So now you can take these stem cells, and in association with biological matrices, you can create various structures, anatomic structures, to hopefully reconstruct a defect. So we've all seen, I think, the ear growing on the back of a mouse. But this is, this is a tissue engineering experiment that basically shows the power of stem cells and biological matrices together. So in this particular experiment, a polygalactin matrix has been fashioned into what looks like an ear. And then it's seeded with adipocytes or chondrocytes, and then those cells then replace the matrix, retain the morphology of the construct, and then you have a biological structure that you can then transplant. But this can be done for basically any cell type in the body. A lot of research has been done on neovascular conduits, again, driven by combat needs. You can imagine those patients that I showed in that picture, those injuries. When you get multiple amputations and you need some kind of vascular reconstruction, you really have a paucity of vein. Vein has been traditionally the vascular conduit of choice. But when you don't have vein, you need some other answer that you can pull off the shelf and reconstruct these patients' vascular structures. So in this case, what you can do is typically you would have a cylindrical collagen matrix that you can then seed with smooth muscle or adipose-derived stem cells. And then they replace this matrix, and then oftentimes you put them through the standard physiologic stresses that they'll have with pulsatile flow, and they'll recreate the morphology of a blood vessel. And this is just an example of how stem cells can advance and reconstruct various structures depending on their association with biological matrices. So in addition to associating them with biological matrices, we found that, again, stem cells reverse radiation damage. They can improve skin quality. They can soften scars in massively burned patients. They promote angiogenesis, and they can regenerate fat lost by aging and atrophy. But there's a lot of questions remaining with stem cells. We haven't been using them long enough to know what the oncologic potential is with them, dysregulation. We need to learn how to achieve optimal growth and regulate their growth and reliably control their differentiation. And we just, it takes time to really realize the long-term effects of these therapeutics. But theoretically, down the road, we can help heal damaged organs. We can prefabricate flaps and potentially prefabricate organs. We can regenerate cartilage in patients with either nasal or auricular defects or osteoarthritis. We can engineer vascular conduits that have much more have greater potential for long-term patency. We can regenerate nerve, which is a dire need, which we'll talk about later. Skin regeneration in massively burned patients is obviously a massive need for that. And we can potentially eliminate or minimize the donor site morbidity associated with standard reconstructive surgery. So over the past 10 years, stem cells, no doubt, have taken off. There's a bunch of worldwide meetings, about approximately 50 different journals dedicated to stem cells. I want to bring special attention to this meeting, the World Stem Cell Congress, which will be actually in San Antonio in December. This is the largest meeting in the world for stem cells. Now on to reconstructive surgery. What is reconstructive surgery? Reconstructive surgery is surgery performed on abnormal structures, most oftenly caused by trauma, but could be congenital infection, oncologic, and it's performed to provide coverage, improve function, and oftentimes to approximate a normal appearance. This is not Dr. 90210 stuff. This is truly this is what I call a true plastic surgery, an attempt to help recreate what a normal structure rather than creating an aesthetic structure over top of a normal structure. So to further define reconstructive surgery, we often refer to the reconstructive ladder. And this basically outlines how reconstructive surgeons think about the complexity of the reconstruction that they're about to take on. As you go up the ladder, it increases in complexity. And what I'll focus on primarily is the top two rungs of the ladder, free tissue transfer and vascularized composite allotransplantation. So free tissue transfer refers to, again, taking tissue from one part of the body, moving it to another part of the body to reconstruct the defect. You take along its vascular pedicle and you plug it into a recipient vascular access at the site of reimplantation to reconstruct a major defect. So on the left here you see the progression of a mandibular reconstruction using fibula. So this is a picture of a leg in which the fibula has been dissected. An osteotomy is performed to approximate the shape of a mandible, and this has been plated in situ. Over top of this, then, is adipocutaneous flap that allows soft tissue reconstruction in conjunction with the bone. And then this is harvested in continuity with the perineal vessels. So then you can bring that up to the mandibular defect, plate it in place to replace the mandibular bone, anastomose the perineal vessels, artery and vein, 2 branches of the external carotid and internal jugular, to again restore the function of the mandible and potentially down the road approximate a normal appearance by implanting dental implants into the bone. On the right here is this is actually a case from Afghanistan where a soldier sustained a blast injury to the anterior ankle, exposing tendons and vessels and nerve that obviously can't take a skin graft, requires much more complex reconstruction. So in this case, we harvested a radial forearm flap in continuity with the radial artery, and then brought that down to the leg and plugged those vessels into the anterior tibial artery and vein. And then that produces a reconstructed defect. And then the donor site can then be skin grafted because it has vascular structures, vascularized tissue that you can skin graft over top. So that's standard reconstruction. That's the top of the tier standard reconstruction. But again, there's no standard reconstruction that's going to fix this. So this is a mangled arm from a blast injury, and this is a patient that suffered an RPG to the face. This patient on the left is going to require an amputation. There's no standard reconstruction that can reconstruct the complexity of the hand and arm. And then on the right, this patient will live. You can live without a face, but you can't live any meaningful life. So in order to restore form and function, however you define it, we need to step up a level on the reconstructive ladder. And the only way that you can reconstruct these is with transplantation currently. So broadly defined, reconstructive transplantation is not just hand and faces. It's basically any tissues of complexity that can be reconstructed with cadaveric tissue. We focused primarily in the media on hand and faces because ethically these create such a quality of life improvement that we get around some of the ethical problems of giving immunosuppression to patients for a non-life-saving therapy. We'll talk about that a little bit more. So vascularized composite allotransplantation has great potential, but it really is limited by several factors right now. First, it requires systemic immunosuppression, just like livers, hearts, lungs, and that creates infectious, neoplastic, and toxicity risks. So it's really limited to very few indications that can potentially get around these ethical questions. The skin component is highly immunogenic. It's the most immunogenic tissue that is transplanted. So that often creates an even greater need for higher levels of immunosuppression. It's highly exclusive selection. You have the psychology of it. You have to look at this. You don't have to look at a liver that's transplanted, but you have to look at the hand every day and know it's not yours. And can you incorporate that into your body? You have to match not only immunologically, but you have to match color, sex, size. So there's a lot more criteria that go into patient selection. So that really limits the donor pool for these recipients. So again, VCA has great potential to reconstruct these complex defects, but we really need to advance immunomodulation and get around the problems of neoplastic, infectious, and toxicity risks that come along with it. So that's where my research comes in. So I developed this RESTORE program, and RESTORE stands for Restorative Endeavor for Service Members through Optimization of Reconstruction. And the main purpose of this is to really pursue a translational science, meaning going from the benchtop to true clinical use, to help replace this composite tissue loss. This patient here is the single hand transplant patient we did at Wilford Hall several years ago. She is doing very well. She suffered a unilateral amputation at the mid-forearm level from a mail bomb that she received. And she is a patient that would undergo this procedure again. She's one of those rare patients that has been very compliant and kind of the ideal patient. She's required some revision surgery to help free up some tendons, but she has had definitely better function than she would have had with a prosthesis. But she's on chronic immunosuppression. And so the question is, can you ever really, truly get informed consent from these patients? All of these patients will want, surely, their arm replaced, right? But can you really get across to them the implications of long-term immunosuppression, lifelong immunosuppression, the years that will come off of their life, the complications they may have? That's the question. Especially in young, imagine in young soldiers that have amputations, 18, 19, 20-year-olds. Very difficult to get true informed consent on these patients. So with my research, I have basically two main thrusts. One is to study the ischemia reperfusion injury that's obligate anytime you transplant tissue, and try to reduce that ischemia reperfusion injury. And then to advance what we call donor-specific immunomodulation, so modifying the tissue that's transplanted rather than the systemic patient physiology. So in order to do this, we just don't rush out into the clinical arena. We have to develop large animal models to study this. And so I've developed two different large animal models. One is a gracilis myocutaneous flap allotransplant. And this is the gracilis muscle, just as in a human, lies in the medial thigh. It's not a muscle that either we or a pig cannot do without. It's kind of a redundant muscle. But we harvest the gracilis muscle in continuity with the cutaneous portion that's perfused up through the muscle, and then we harvest it with its blood supply, and we then transplant it to another pig. So this contains skin, which is very important to study in composite tissue allotransplantation, fat, muscle, nerve, and vessels. And that's why it's called composite tissue transplantation, because it contains tissues of multiple types. And then we've developed a true four-limb orthotopic allotransplantation, the only true orthotopic allotransplant in the world in an animal. And the advantage of this is it contains skin, fat, nerve, vessels, but also contains tendon and a large bone component with association of its bone marrow. And that has immunologic implications and becomes much more relevant to true hand transplantation. So this is a depiction of the gracilis myocutaneous flap allotransplant model. So you can see here, this is the pig's medial thigh. The gracilis muscle has been dissected free with its overlying cutaneous paddle. Then the vascular pedicle is here, the artery and vein. Then that's divided and brought up to the neck, where it's sewn into the external carotid artery and internal jugular vein under the microscope. So it creates an allotransplant, heterotopic allotransplant scenario. And we do it in the neck because of the ease of the technical procedure, but also so the pig can't get. And, pigs are, you can imagine the difficulty with basically a free flap model where you transplant a portion of the pig to another area. The pigs have afterwards to do whatever they want, run down, kennel and and all this. So it's really been a godsend that this is a robust model that is reliably reproducible. And that's why we transplant it in the neck, so they can't chew on it and roll on it. So again, that's a picture of the vascular anastomosis, the artery and vein here. As in all reconstructive surgery, we do typically use vein couplers instead of actually sewing. You guys don't ever use vein couplers, right? It's a nice adjunct because they're basically two cylinders that have spokes on them. You bring the vein up through it, and you basically splay the vein over top of the spokes on both sides. Then the spokes come together and create an anastomosis that is tented open so it doesn't collapse. And then in association with that, now they have these Doppler probes that can actually listen to venous flow as it goes across them. So that's the flap after it's been transplanted. In the first couple days, it begins to integrate. And when we initially created this model, we did an auto transplant just to prove its efficacy and reliability. And we found that these integrate very well after just a few days. Here's the actual control allotransplant that doesn't receive any kind of therapy. You can see initially we usually take these flaps out about 3 hours under cold preservation conditions. So immediately after transplant, it's a little bit angry, but that settles down. And then after about 7 days, it's well integrated with no sign of rejection. And then about 7 to 10 days, it begins to show signs of rejection, and you have fluid rejection typically at about 12 to 14 days, reliably. These little spots here are the skin biopsies that we use to monitor the histology of rejection. And these are full thickness down through the skin, down into the muscle. So here's a depiction of the true forelimb allotransplant model. So this is significantly more technically challenging and took really the greater part of the last year to develop. We've defined the vascular and nerve anatomy of the pig's leg, and then the muscular tendinous component, and then devise ways to plate the bone post-operatively or after transplantation to allow it to be weight-bearing. Because again, these pigs aren't going to sit in the bed and hold their leg in any kind of way that's going to protect it. So we've got to make up for that by using weight-bearing plates, and on top of that, you'll see we use casts. And we sedate them for a couple days, but they tend to do pretty well. So the post-operative care is almost as complex as doing the actual procedure, and that all needed to be worked out. But now we found that these pigs will ambulate on 3 legs, and they can feed themselves and drink and maintain and be pretty comfortable. So this is actually developing into a robust model. We haven't done any true transplant studies with the forelimb yet. Most of them have been done with our gracilis flap. So with regard to the ischemia reperfusion arm of the research, we've gone down a couple different paths. One is the use of hydrogen sulfide to produce, quote, a suspended animation state in the tissues. So back about 8 years ago, in association with DARPA, which is a super secret military research agency, they found that if they took millworms and exposed them to an environment or an atmosphere of hydrogen sulfide, they could take their metabolism down to nothing. So they truly create a suspended animation state in these worms. So then they stepped that up into small animal, into rodents, and they found they can take a mouse that normally has a heart rate of about 120, take it down to about 8 to 10 for an extended period of time, bring them out, reoxygenate their environment, bring them out rapidly, and then they still perform their maze tests and everything just as they did before. So with that in mind, the idea was, can we take these transplanted tissues, immediately after removing them, perfuse them with hydrogen sulfide to saturate the tissues, then potentially leave them for a significantly longer period than standard ischemic tolerance, and can we still maintain a tissue that has integrity and doesn't necrose? And so we've developed very sensitive measures within our model to measure biomarkers of cell death. And we'll talk about a little bit about the results in a minute. And then we also, in tandem with that, have been developing a warm ex vivo hyperbaric perfusion system. So in this case, you take the tissue out, you put it onto a system that has an oxygenator, a rolling pump to perfuse the tissues, and then it's in a very small hyperbaric system. So the tissue, basically what we've done so far is we've taken Wisconsin solution at room temperature. It's not at physiologic temperature, and it's not at cold. But we take Wisconsin solution and hyperoxygenate it hyperbarically so that the PO2 of the solution is now over 400. And then perfuse that tissue for an extended period of time, again, past the normal ischemic interval, to study if we can maintain metabolism and preserve that tissue. And the implications of this are pretty great. You can imagine, right now we're limited, our donor pool is somewhat limited by, travel time. So if you could have a system that can maintain an organ, a fairly small portable system, that you can reliably maintain an organ, and basically the tissue really feels like it's still in vivo, theoretically. You could potentially take an organ from Miami and transplant it in Seattle if you can truly maintain the metabolism of that organ. And so, this is not the only system out there. There's several other systems that are in development. Some have perfluorocarbon-based oxygen delivery. Some have hemoglobin-based oxygen carriers. But the beauty of this is that it truly has no oxygen carrier. It's just hyperoxygenated Wisconsin solution. So, without going into too much granularity in the findings, we found that H2S, it doesn't knock out ischemia reperfusion injury, but it certainly ameliorates it. If you have if we measure biomarkers of cell death and we take a control, we can significantly blunt the release of these biomarkers that signal cell death. And in doing so, we've also found that it delays acute rejection. Both the H2S and the warm ex vivo perfusion will significantly delay acute rejection with no therapy whatsoever other than ameliorating the ischemia reperfusion injury. We found so far that up to 14 days, the warm ex vivo perfusion completely prevents ischemia reperfusion injury as judged by biomarkers and histologic evaluation. We haven't taken it out any more than about 12 hours, but hopefully at some point we can take it out about 24 hours and see if we can truly preserve these tissues for 24 hours. So the question remains, why are we delaying acute rejection when we're ameliorating ischemia reperfusion injury? And the theory there is that if you can stabilize the tissues and prevent these cell lysis and this basically antigenic storm that's created by ischemia reperfusion injury, then you make the tissue potentially less immunogenic to the host and could potentially delay acute rejection. That certainly doesn't mean that you don't need to use immunosuppression, but it may delay it or may prevent you from having to use induction therapy theoretically. So as far as the immunomodulation part of this, we work in close association with the University of Pittsburgh, both their transplant folks and the regenerative medicine folks at the McGowan Institute. But in conjunction with them, we've been able to obtain subcutaneous drug-eluting microspheres. And basically what we do in this situation is we can implant these drug-eluting microspheres in the immediate subdermal area and then transplant these without any induction or maintenance immunosuppression otherwise, no systemic immunosuppression. And we've seen that we can delay acute rejection greater than 28 days, as judged again by biomarkers of rejection and histology. What's really exciting to me, though, is this immunocloaking technology that's coming our way. So in conjunction with the Brionics Corporation, who's developed this technology, we are going to employ a system, another warm ex vivo perfusion system based on perfluorocarbon oxygen carrying. But while it's on that system, it's basically captive, and you can really perfuse it with whatever you want. So in canine kidneys, what they've done is they've developed a solution of various oligopeptides that they perfuse through these kidneys for about 8 hours. And what happens is that it sets down essentially another basement membrane on top of the endothelial antigens so that it masks these endothelial antigens without inhibiting diapedesis and any physiology going through the wall. So they've been able to take these kidneys out about a month, again, without any immunosuppression, just with this immunocloaking. But again, this degrades over time, so it's not the ultimate answer. But potential reapplication or engineering the basement membrane to last longer could potentially have an answer for donor tissue-specific immunomodulation only, obviating the need for chronic immunosuppression. And we hopefully will be getting that within the next couple months. So in summary, restorative medicine is rapidly evolving. All of this work that I've been talking about has really been a result of DoD investment even though a lot of it has been civilian, they get their money from DoD because they see the need for improving the care and advancing regenerative medicine for the sake of our troops. As the war draws down, a lot of the money is going to be taken away from point of injury care and saving lives on the battlefield, and hopefully more towards regenerative medicine and rehabilitation. Hopefully. But you never know. Vascularized composite allotransplantation, again, you can see has a real potential for reconstructing previously non-reconstructible injuries, but we really, in order to unlock this field, we need to advance the science of immunomodulation to get around the ethical problems of giving these guys immunosuppression. Just a quick plug for anybody interested in regenerative medicine. There's a Regen Med SA meeting next month, February 13th, 14th at UTSA. And that's a meeting where we bring together industry, academics, and military folks to promote collaboration within regenerative medicine. And then again, the World Stem Cell Summit will be here in December at the Henry B. Gonzalez Convention Center. So we do our research at basically 3 different labs in town. Wilford Hall still has a clinical research division where we do some of the flaps. We have work being done at the TSRL, which is a massive lab, 120,000 square feet at Fort Sam Houston, and then at the U.S. Army Institute of Surgical Research. Our research is funded by Air Force Medical Service, DARPA, and the U.S. Army Medical Research and Materiel Command. This is a picture of the Battlefield Health and Trauma Institute. Beautiful building, very un-Army-like, brand new, but a great place to do this research. This is the Wilford Hall Clinical Investigations Division, and this is the TSRL. A massive building that has non-human primate capability too. We have multiple academic and industry collaborators. We'd love to get UT Health Science Center on here too, so we can talk about that later. All right, with that, any questions? That
was fascinating. I imagine the major challenge is not taking on too many projects.
Right, absolutely. So I'm still trying to do clinical work too. So.
I'm curious about a couple of things. A lot of advances are incremental. It seems like rejuvenating cartilage would be more simple than some of the things you've done. And lots of people get hip replacements because their cartilage wears out. Is rejuvenating cartilage something that you think is doable?
I think absolutely at some point. You know, there's a lot of ideas out there right now where they take adipose-derived stem cells, harvest them, and then just inject them into the joint. And it's hard to believe that that truly gets to the right place to really rejuvenate cartilage. I think maybe the answer will be taking stem cells in vitro, creating a cartilaginous construct, and then implanting that back rather than just injecting these into the joints. But you may have heard of some of the spurs, you know, having injections of stem cells in their hips or knees, and then magically they're doing better. I personally have a hard time believing that that's truly helping them, but Tim Duncan has had it. So,
another question is, with your hydrogen sulfide experiment, did you consider that maybe limiting ischemia reperfusion is not what's affecting your outcome, but it's downregulating components of the immune system? Did you look at that?
absolutely. So we have various, you know, we have a panel of immunoreactive assays that we do. Again, this is all theoretical, and we haven't figured out the true mechanism of why we see delay in acute rejection. But we definitely see, and the whole purpose really of going down the ischemia reperfusion pathway and trying to evaluate that was the theory that in the literature that various authors have shown that limiting ischemia reperfusion will delay acute rejection. Again, not the ultimate answer, but yeah, we have not truly figured out the mechanism of why H2S delays acute rejection. And it's only, in the big picture of things, if you're thinking about a clinical application, it's only a few days, you know, that it really ultimately, on average, delays acute rejection, but it's statistically significant. So something's going on there that we need to figure out. But right now, it's of no real true clinical significance. It's still in the basic science area. But again, in association with the University of Pittsburgh, we're really trying to, one experiment at a time, we're trying to figure out mechanistically what's going on. So that's definitely on our